Okay, I think in interest to stay on time, I'll go ahead and introduce our next speaker, one of my practice partners. So our next speaker is Dr. Stephanie Wong. She's an orthopedic surgeon and sports medicine specialist who cares for patients of all ages with hip, knee, and shoulder injuries. She earned her medical degree at UC Davis and did her residency in our own UCSF Orthopaedic Surgery Residency Program. And then she completed her fellowship at Rush University Medical Center. While at Rush, she served as assistant team physician for the Chicago White Sox, the Chicago Bulls, and Chicago Steel. After fellowship, we were lucky to have her come back home to the Bay Area and also join our department. And Dr. Wong is a part of the UCSF Hip Preservation Center, and she has an expertise in injuries and conditions about the hip. She has a special interest in advanced arthroscopy for hip preservation and use of patient-reported outcomes to guide decision-making with surgery. In fact, she is a recent recipient of the prestigious Stephen P. Arnowski Young Investigator Grant from AOSSM for her groundbreaking research in hip preservation. She is the perfect person to speak with us today about the most common hip problems in our patients. Please welcome Dr. Stephanie Wong.
Thank you so much, Dr. LaRoque, for that very kind introduction. And I'm really excited to be here with y'all tonight and excited there was no real tsunami. So we'll go ahead and get started. These are my disclosures. So the objective of my talk this evening is to recognize some common causes of injuries to the hip as well as hip pain, identify indications for obtaining proper diagnostics, and then reviewing the non-surgical and surgical management of these hip conditions. So I wanted to give you a roadmap for what we're going to cover today. And as my realtor likes to say, location, location, location. Many conditions in the hip, you can narrow down your differential diagnosis based on the location of their pain. So I want you to kind of keep this in mind as we go through the talk as well as the physical exam today. So for conditions that localize to the anterior hip or the groin, we think about femoroacetabular impingement, hip osteoarthritis, avascular necrosis of the femoral head, stress fractures, and then slipped capital femoral epiphysis, especially in our adolescent patient population, and that's essentially a growth plate fracture of the proximal femur. Now for the lateral hip, very commonly we see trochanteric bursitis as well as gluteal tendon tears as well as tendinopathy. And then finally, if the patient has pain localizing to their posterior hip, we think about posterior pelvic pain, including the SI joint, as well as lower in the buttocks or gluteal region, proximal hamstring injuries and proximal hamstring tendinopathy. So I wanted to go through a couple cases just to kind of illustrate some of the typical presentations. This first case is a 34-year-old male who's presenting to your clinic with groin pain for the past year. He denies any injury. He notes that pain is worth with sitting, squatting, basketball, and CrossFit. He's still able to out-jump our chair, Dr. Ma, though, given this in this photo. And he notices slightly limited motion of his hip. So this is a classic presentation for a patient with femoroacetabular impingement. So they typically present with chronic anterior hip pain. It affects a really wide range of patients, anywhere from our adolescent patients up to our middle-aged patients. And this condition essentially occurs where you have abnormal contact of the acetabulum and the femoral head-neck junction. And this can result in kind of abnormal bony remodeling and then subsequently labral tears, cartilage injury, and then the subsequent inflammation can then go on to develop arthritis. And we'll kind of talk through some of the pathophysiology here in the next couple slides. So as some of you may know, there's a couple different types of femoroacetabular impingement. There's a pincer type, and this is a condition where people are generally develop this, and basically they have an extra deep socket is how I think about it. So they have acetabular overcoverage. And in this video you can see, you can see how when the socket is extra deep, when you go to range the hip, the femoral head and neck basically impinges or runs into the acetabulum earlier than if you did not have this extra deep coverage. And then you can see here the labrum is that soft tissue triangle that's getting deflected with that impingement, and that's what subsequently leads to the labral tear. So it's really a bony originally problem, and then the labrum gets involved later. Cam impingement you can think of as a problem on the other side of the joint, so on the femur side, and that's basically a bony prominence that actually develops during adolescence. So oftentimes in active individuals, as they play sports, run, jump, kick, they're gonna have that portion of the femur, which is actually where their growth plate ends. That's the proximal femoral epiphysis. That's actually going to bump into the acetabulum repeatedly with that motion, and then they get this kind of bony prominence that grows there. So in the natural history studies, if you take x-rays of kids when they're 10 or 11, they don't have cam deformities, and then when you follow them, you take x-rays maybe when they're 19 or 20, you actually see this develop. So it's a little bit different than the pathophysiology behind a pincer. And then this is kind of just a little animation showing that cam deformity. So it's kind of a anterior, kind of sometimes lateral deformity. And again, same thing. You flex the hip up, and that bony deformity bumps into the labrum and then can cause labral injury and cartilage injury over time. And then in some patients, you have actually a mixture of both, so then we call that mixed type. All right, so moving along to the hip labrum. So this is a protective ring of fibrocartilage that goes about 270 degrees around the hip socket. And it contributes to both hip stability as well as the suction seal of the hip joint. Now, labral tears are very, very common. I'm sure many of you have probably seen them in your practice. And in patients with FAI, over 90% of patients actually have labral tears. And there's actually been some studies shown where if you have a patient with femoroacetabular impingement on their x-rays, some hip arthroscopists are actually arguing that you probably don't even need an MRI before you do surgery because they're all going to have labral tears anyways. Okay, we still get MRIs on everybody before we do surgery, but there's actually been some people proposing that maybe the MRI is not fully necessary because we kind of know what we're going to see. And then interestingly, this study out of Vail, they MRI'd a bunch of people in their 30s who were asymptomatic, and then 70% of them have labral tears. So I see this a lot in my clinic where patients get referred in for the radiographic or MRI finding of a labral tear. But what I really want to go through is kind of how to correlate that with their clinical symptoms and determine whether that's an incidentally found labral tear or if it's actually causing their symptoms. Because I think, in someone over in their 30s, it can oftentimes be either an incidental finding or kind of a degenerative finding, similar to the shoulder labrum in your older patients. All right, and then because this is a sports medicine conference, I wanted to put this slide up, and I was curious what you thought these athletes have in common, besides them being all male. All right, so we have NHL hockey player, we have Buster Posey, and then we have Alex Rodriguez. They all actually had femoroacetabular impingement, and they all had hip arthroscopy for their condition. So this is just to illustrate that we have a very high prevalence of FAI in our athletes. So out of those at the NFL Combine, over 90% of them had at least one sign of FAI on their radiographs, and then about 75% of elite youth hockey players had a cam lesion. Now, these are just radiographic findings, right? Doesn't necessarily mean they have symptoms. So what I want to go through next is kind of our clinical presentation of femoroacetabular impingement syndrome, and we differentiate this from FAI because these are the patients that actually have the clinical symptoms that go along with it. So in terms of their history, they're similar to that 30-year-old basketball player we talked about earlier. They describe anterior hip pain. Sometimes they'll actually take their hand and go like this in a C and put that on their hip. And then for those of you who can't see my hip, you can see it in this photo here, but they'll actually say like it hurts in this distribution. Typically worse with sitting and worse with activity or sports. We'll go through the exam in a moment, but they typically have a positive fader sign, which stands for flexion, adduction, and internal rotation. And then they'll often have a subtly limited hip internal rotation as well. And sometimes this can just be by a couple of degrees. So I'd always encourage you to examine the contralateral hip to be able to tell the difference here. On their imaging, so because I'm an orthopedic surgeon, I get x-rays on everybody before I even meet them. And what this will typically show is, this bony prominence, and you can kind of see this demonstrated by the green arrows. And so you kind of see this sharp corner, and you can differentiate this from a typical osteophyte of osteoarthritis because this patient has preserved joint space. We also like to get laterals just so we can see the other angles from the hip. And again, you can see here the arrow points to that big bony prominence, and this is a big cam deformity in this patient. For those that fail non-operative management, we'll also typically get an MRI. This happens to be an MRI arthrogram, so this is one where they inject gadolinium dye into the hip. That does tend to show us the labral tears a bit better. Those who have access to better MRI scanners, so 3 Tesla machines, for example, you oftentimes don't even need gadolinium to be able to see the labral tears. But this is a nice example. You can see here the cleft of gadolinium dye going between the labrum, which is this black triangle in cross-section, and then the acetabulum starts here. You can also see pretty clearly this big cam deformity that kind of matches with this patient's x-rays. So in terms of treatment, how do we typically treat these patients? So in my opinion, treatment is typically non-operative to start, and I think a trial of non-operative management is always indicated for this group of patients. So we work with our physical therapy experts for core, gluteal strengthening, pelvic stability exercises, such as the ones you can see here. So resisted hip abduction, hip bridges, and then every physical therapist's favorite exercise, clamshells. My sister's a physical therapist, so she told me to say that. Also, you can consider intra-articular injections. So we think about things like steroid. Nowadays, you can also inject Toradol into the hip joint itself, and there's thought that maybe that is a little bit more safe or less chondrotoxic than some steroids. So if your patient's concerned about steroid into the joint, you can consider Toradol, which is an NSAID. And then finally, PRP or platelet-rich plasma is also an option as well. If you're going to consider an injection, I always tell people make sure it's image-guided, just because the femoral neurovascular bundle's close by, and then you just want to, in terms of accuracy, your accuracy is going to be better with either ultrasound or fluoroscopic guided images. And then for those patients who still have pain despite non-operative management, of course, you can consider surgery. So these are just some photos from a right hip arthroscopy that I did. This is looking inside the hip joint. And then you can see on the right-hand side of the screen, just to orient you, this is going to be the femoral head on the right-hand side, and then the acetabulum on your left. And then kind of the patient's torso or kind of front of their hip is this way, so anterior is up here. This is the labrum, and you can see right here the labral tear where the labrum is kind of drooping into the hip joint. And to do this surgery, we use a special table where you actually put the patient's feet in kind of these ski boot contraptions, and then we actually distract the hip by about 1 centimeter to be able to actually get inside and do our surgery. So this is an image showing our repair. So essentially what I do is place an anchor into the acetabulum, and these anchors are very small nowadays. The specific anchor is about 1.4 millimeters in diameter. These anchors have non-absorbable sutures that come out from that, and we use that to loop around the labral tear and then sew the labrum back up to the socket, and that's what completes the repair. Once we're done with that, we'll put the hip back into the socket, and then now we're in the peripheral compartment. So this is looking down on a cam lesion, which you can kind of see here, this big deformity. And then we use a burr to resurface or smooth out that bump so it's more convex. This is an image of the completed, what we call femoroplasty, and then kind of a different angle here. And then at the very end, I'll actually repair the hip capsule, and that oftentimes does contribute to stability and some would say better outcomes after the surgery. Interestingly, there's been actually a couple good, large, randomized controlled trials done comparing non-operative treatment for FAIS to surgery. This study out of the Lancet in 2018 looked at how patients did with each treatment, and they randomized about 350 patients either to hip arthroscopy or physical therapy. The crossover rate from physical therapy to surgery was about 8%. And if you can see here in this diagram, essentially at 12 months follow-up, the hip arthroscopy group, which is in the top line in red here, had significant improvement over the physical therapy alone group. It's important to note that both groups did improve over baseline, so I do share this data with patients and say essentially both groups improve. The surgery group tends to improve more. But in total, if you look at the patients that end up getting a hip arthroscopy, out of every patient that presents with hip impingement, it's about 20% or so across the world so that gets surgery. So I tell people that means there's 80% of people who succeed with non-operative treatment. So I think it's reasonable that therefore to trial non-operative management first. This is another study looking at, again, randomized clinical trial of 7 National Health Service centers out of the UK. And again, they randomized 222 patients to surgery versus PT. And they look specifically at one of the hip outcome scores called the hip outcome score. And the hip arthroscopy group, again, here on the right, did improve more than the physical therapy group at final follow-up. So in terms of return to sports and activity, this systematic review showed really high levels of return to sport as well as return to same level of competition after hip arthroscopy for FAIS. They're quoting 88%, 92% return to sport. So I think in the correctly indicated patients, this can be a really successful surgery. One thing that we haven't talked about yet is when to not do this surgery. And the studies can pretty much across the board all note that if you already have hip arthritis, labral repair surgery is not going to be effective. And if you treat meniscus tears and the degenerative version of those, you do know that there are also a lot of really good randomized controlled trials that have looked at whether surgery is helpful for meniscus tears in the setting of osteoarthritis, and they're not. So it's kind of same thing with the hip. So if they already have joint space narrowing and their hip is really stiff and painful, they're probably already, unfortunately, turned the corner to arthritis, and those patients may not benefit from arthroscopy. And then if you're not sure, I think referral to specialists can help kind of understand that differentiation. Okay, so why do we care so much about femoroacetabular impingement? It seems really common. Okay, fine, people have labral tears, but not all of them are symptomatic. We care because if untreated, FAI can lead to chondral injury, labral tears, and actually it's one of the most common reasons for early onset hip arthritis. So FAI, in addition to hip dysplasia, make up about 90% of the people that are getting arthritis in their hip before age 50. And so you can kind of see in this x-ray, this patient, you can kind of see this cam deformity here. They've gone on to develop joint space narrowing, sclerosis, and this patient essentially has arthritis and they're no longer, unfortunately, a hip arthroscopy candidate. So then, the question after this is, if you identify hip impingement on x-ray, should we be more aggressively treating these patients when they're younger so we can change the natural history of arthritis? So this was a nice study that came out earlier this spring, and it's probably one of the longest follow-ups that we have. Modern hip arthroscopy, just for your information, actually started around 2000, which is relatively recent. We were doing knee arthroscopy back in the 70s, actually, but it took us until about 2000 to develop the tools to actually get into the hip joint and to be able to actually develop tables to actually distract the hip joint enough that we can work inside of it. So this study out of HSS looked at hip arthroscopy and how it might change the natural history of developing arthritis. So they looked at 100 patients at 12 years follow-up, which is actually very impressive to be able to contact that many people at 12 years after their surgery. And they compared the operative hip to the asymptomatic contralateral hip, which of note also had radiographic hip impingement but did not have symptoms. And they noted that hip arthroscopy, so the side that had surgery, had a 42% less chance of progressing to osteoarthritis compared to the contralateral side. And then they noted that risk factors for OA progression included borderline hip dysplasia, so a slightly shallow socket, older age patients, worse baseline arthritis, as well as worse cam deformity or cam impingement. I would say that this is a really interesting study because it's basically the longest term follow-up we have and suggests that hip arthroscopy may change the natural history of arthritis. But I would emphasize that this is only based on radiographs. So this has nothing to do with patient outcomes. We don't know if their hip is actually painful or if it just has arthritis on x-rays. So I would say it does prevent hip arthritis, but mainly just on x-rays. And we always know that some patients have arthritis but no symptoms. So I think the jury's still out if we should be doing these surgeries on asymptomatic patients. All right. So moving along to some other common hip conditions that you might see in your clinic. This is a 60-year-old male with worsening atraumatic anterior hip pain for the past 5 years. He's limping. He tells you that he really likes his new pickleball league that he's in, but he really can't keep up with his partner. He notices trouble putting on his shoes and socks. So this is a classic description for a patient with hip osteoarthritis. And, as we just said, this typically affects patients that are over 50. Usually they describe chronic groin pain, and they might describe kind of achiness, stiffness. A lot of times they'll often say they have difficulty walking longer distances and difficulty with shoes and socks, specifically because those involve hip rotation, which they are going to have difficulty doing. On exam, they'll have limited hip motion, and then on x-rays, you'll see the classic osteoarthritis constellation, which includes joint space narrowing, osteophytosis, and then sclerosis, or more whitening of the bones adjacent to the articular surface. And then I always think it's really important to compare normal to abnormal, so you know what abnormal looks like. And this, for your reference, is kind of a normal hip x-ray, where you can see the contours of the bone are really smooth, the joint space is nice and symmetric and open, in contrast to the x-ray above, where you can see, for example, on this left side, narrowing here, some osteophytes a little bit lower down, and then sclerosis, or increased whitening of the bone adjacent. So in terms of non-operative treatments for hip osteoarthritis, the AAOS clinical practice guidelines, which is our National Society for Orthopaedic Surgery, our clinical practice guidelines have strong recommendations for treating pain with anti-inflammatories, intra-articular steroid injections, as well as physical therapy. And this is an image showing kind of our intra-articular injections, either fluoroscopic guided on the left or ultrasound guided on the right. And then I added weight loss in here as well, just because we know the joint reactive forces do increase with increased weight. And I do think that's an important thing to also consider in terms of symptom management. Now, for those patients who have continued symptoms, not responding to non-operative management, of course, you can consider hip replacement. These have actually continued to improve in terms of the material and bearing surfaces. So I graduated from residency in 2019, and I will say the replacements that people are getting are actually probably slightly different than the way I even learned them, 5 years ago. And that's just referring to the type of bearing surfaces. For example, this shows like a metal on plastic. So the femoral head here is metal. The surface between is plastic, and then this cup here is metal. And the materials have really kind of evolved and changed to include ceramic components, as well as some highly cross-linked polyethylene, which is that plastic liner that may have better wear properties for some of your younger or more active, high-impact individual patients. This is what it looks like on x-ray when done well. And then this is a graph just showing, this is actually combining both total hip and total knee arthroplasty, but this is from the National Registry in the United States, just showing the kind of continued increase in both total hip replacement and total knee replacement yearly. We anticipate that this is going to continue to keep going up. Now, in terms of hip replacement outcomes, I have a lot of patients who ask me about this. Overall, really, really excellent outcomes in over 90 to 95% of our patients, with that number of them achieving MCID out of this joint registry. Longevity of the implants, again, I think is improving. So survivorship is oftentimes 15 to 25 years plus. So survivorship tends to be longer in older, more sedentary patients, and shorter in younger, more active patients. And these are just some numbers just from this publication, but you can see at 25 years, about 78% of their patients still have their original total hip replacement. And then I think, what's important to also think about for total hip replacements, while millions of people get these and do really, really well, there are rare but serious complications with this. They include things like dislocation, periprosthetic fracture, as well as infection, and oftentimes these complications do need to be treated with revision surgeries. So just something to keep in mind. Finally, I wanted to bring up GLP-1 agonists as well as how they interact with arthritis. So how many of you, maybe show of hands, either prescribe GLP-1 agonists or know someone who's on them? Oh my gosh, it's like 80% of the room. Yeah, so I think, what's interesting about this is that, in addition to obviously the effect on diabetes, weight loss, GLP-1 agonists can actually maybe affect osteoarthritis as well. And we know that a lot of these conditions sometimes coexist. So there's been data showing that GLP-1 agonists can modulate immune response and actually inhibit inflammation. And I mentioned to you earlier, in terms of hip impingement, one of the leading causes of the development of arthritis is kind of that synovitis or inflammation in the joint. So the fact that GLP-1 agonists might modulate that is really interesting in how it might play a role in the natural history of developing arthritis. They have been shown to improve pain in an OA mouse model. So the question is this the next disease-modifying osteoarthritis drugs? With regard to things like rheumatoid arthritis, we almost never operate on rheumatoid arthritis patients anymore in orthopedics compared to years ago, just because of some of the biologics that they're being treated with now and the joint preservation that's resulted. So, I think the jury's still out. I think we still have a little more work to do in terms of understanding the effect of these drugs on arthritis. This was a recent study published in October that actually showed, interestingly, a greater risk of progression of hip and knee osteoarthritis amongst obese and non-obese patients that are using GLP-1 agonists. So we don't exactly know why that is. But I think, still unclear long-term effects. I think I'll be very interested to see, what we're talking about at this conference in a couple of years with regard to this. All right, so switching gears to talk about another type of hip condition. Your 58-year-old uncle was water skiing at a local lake this past weekend, and he fell, and he calls you because he knows that you treat patients with musculoskeletal problems, but he doesn't really want to go to, his primary care doctor. So he can't walk. He says he has a lot of bruising in the thigh, and he calls you and says, "What do you think's going on?" So this is kind of the classic story for proximal hamstring injury. Oftentimes these can be acute, sometimes chronic injuries. We'll talk about a little bit about the difference. In the acute setting, patients will often describe an awkward fall. Oftentimes they'll say, "I went into the splits where my legs went apart this way." They'll have a lot of bruising, buttock pain, pain with sitting, difficulty walking. A lot of my patients will bring in photos. If this injury is older, they'll say, "Look what it looked like 4 weeks ago," and they'll have extensive bruising over the entire posterior thigh. And they'll have tenderness over the ischium, weakness with knee flexion and hip extension, because that's the action of the hamstring muscle group. And so in these patients, I always get an X-ray, AP of the pelvis, just to rule out any bony type injury. And then I think importantly, these patients should get an MRI just to understand the grade of their injury, and especially with this type of extensive bruising and mechanism, to rule out a tendon avulsion, which is pictured here in this diagram. Importantly, I would say don't order an MRI of the hip, because if you can look at this diagram here, oftentimes MRI of the hips stop right here. So if this injury is retracted, and sometimes it can be retracted 5-10 centimeters below the ischium, we're not going to see it. I mean, they'll see it. They'll just say the hamstrings are not there. But I think an MRI hamstring order or an MRI femur is going to be much more helpful if you're worried about a hamstring injury involving the thigh musculature, because that'll actually show you the retraction. All right, so we'll talk about some indications for non-operative treatment, typically with things like pain control, physical therapy, and then operative treatments, including proximal hamstring repair. So how do patients do, depending on what treatment they have? So there was a meta-analysis done of about 24 studies showing that patients who got acute repair had high patient satisfaction, good strength, and then improvement in their lower extremity functional score, which is one of our patient-reported outcomes. But they had a really high complication rate, 23%, which included things like peri-incisional numbness, sciatic palsy, including things like a foot drop after surgery, wound complications or wound infections, need for reoperation, re-rupture, or DVT. So obviously, those are all really bad things. And I think that, we have to ask ourselves which of the patients given these risks should have operative treatment versus which are better candidates for non-operative treatment. The studies also seem to suggest that if you are going to do surgery, doing it acutely is probably better than in the chronic setting. Overall, they noted that the overall quality of studies was pretty low. And then I would say that was true up until this study came out, which was published over the summer, which we reviewed at one of our journal clubs. And this was a study that looked at basically randomized surgical treatment to non-operative treatment, and they also had an observational cohort for patients that did not want to be randomized. And then interestingly, this study basically took all comers in terms of age of patients ranging from 30 to 70. Of note, everybody was acutely injured, so these are not chronically injured hamstrings, but acutely injured, and most of them involved 3 tendon injuries, so kind of complete injuries. They concluded that non-operative treatment was not inferior, okay, double negative, but basically kind of similar patient-reported outcomes in both groups. So that's kind of interesting. That basically says that doing surgery maybe is not super helpful. So, my expert level opinion is that I usually reserve surgery for the younger, more active patients, so patients who do sports that require power from their hamstrings. So if you tell me, I love running, I play basketball, I jump, and I need to get back to those high demand activities, and you don't have comorbidities that are going to make me concerned for some of those complications I mentioned, uncontrolled diabetes, smoking, et cetera, then I think it'd be reasonable to consider surgery, and you're willing to accept some of those risks we talked about. Now, the patients who typically actually do quite well, so that'd be people in this study who did well, even though they didn't have surgery, they had full tendon ruptures, are people who are more sedentary. I like to walk, I like to garden. Maybe I'm a teacher and I'm 60. I think those are the types of patients that actually typically do quite well, even though they look really, really, really bad when they first come into the office. Like a lot of people are in wheelchairs and they can't even get up to the exam table, et cetera. So I think just some things to keep in mind. And then I also wanted to share just some images of an open proximal hamstring repair, just so you can see what that looks like. We do this surgery both endoscopic as well as open. Open repairs I usually use for patients with really retracted tendons or chronic scenarios or revision scenarios, and endoscopic is better for patients who have minimally retracted tears or partial thickness tears, which are more in the chronic setting. So in their prone position here, the incision's right along the bottom of the gluteal crease, so it's actually quite cosmetic. And then this is a picture of the proximal hamstrings that are ruptured. We put anchors into the ischium, and then sew the sutures from that anchor through the hamstring. And then this is a picture of the hamstring here. So this is a right hip, and the patient's in the prone position. And these are branches actually from the sciatic nerve that just lie right lateral to it. So again, a little bit kind of tiger territory, I like to call it. So you're working right next to the sciatic nerve. So I talk to patients about possible sciatic nerve palsy or irritation after this surgery. And then, the rehab is really intensive after this procedure. So this would be another criteria for me to consider for non-operative treatment if the patient may not be able to actually do the protocol after surgery. So I typically do 6 weeks of foot flat weight bearing. So that's basically using crutches or a walker in a brace. Physical therapy oftentimes goes for at least 6 months, and then full activity or return to sport usually 6 to 9 months. So really long rehab for those patients. All right. Moving on to a different case. This is a 45-year-old female who is coming in with, again, anterior hip pain for 3 months, no trauma or injury. She's very active. She enjoys running. She tells you she's training for a half marathon, so really needs to get back as soon as possible. She knows that she eats clean. She wants to get back to activity quickly because she's training for this race. So this is a presentation of a patient who actually is a patient I met in my clinic who has a stress fracture. So these can occur in various places in the hip and pelvis, but one of the ones we're most concerned about is in the femoral neck. They can also occur in the sacrum or other parts of the pelvis, such as the pubic rami. And the pain typically localizes to that part of the hip. So as you all know, the hip joint often refers to the groin, or intra-articular pain refers to the groin. And I think what's really important is the history taking here. So I always want to check for patients with, hip pain and no specific injury. I ask them about training programs. So are you training for a race? Have you started any new exercise regimen? I've seen this from HIIT classes that they're not even necessarily running, but any other high impact or loading sports. Ask about their rate of ramp up. Did they go from couch to 10 miles a day, or did they do a slow ramp over many months? And then you want to ask about how they're fueling, any history of disordered eating, things like amenorrhea in females, and then most importantly, history of stress fracture actually predicts future stress fracture, so inquire about that. And then this diagram I like just because it kind of goes over intrinsic factors that are both modifiable and non-modifiable, as well as some extrinsic factors, things like loading, training surfaces, footwear, and then some things we just really don't know about yet in terms of research, things like gut health, inflammation, epigenetics. So in terms of the clinical presentation for these patients, they'll often come in with an antalgic gait. If the bone is superficial, you might be able to elicit some tenderness to palpation, for example, over the anterior tibia. And they might have pain with loading activities or a single leg hop. So anybody that I'm concerned about, I'll actually ask them to get up and hop on that leg. And again, in musculoskeletal medicine, you oftentimes have two of everything. So make them hop on the other leg. Okay, does that hurt? No, fine, that side's normal. Okay, hop on the other side. Painful? And if your spidey senses are going, those are the patients that I would typically then obtain advanced imaging on. So x-rays are typically normal for this. You're gonna get this to rule out other things like arthritis. But I have a low threshold to MRI these patients and have them rest and stop their impact activities. I think to have really high sensitivity for these conditions that you don't want to miss, you're probably going to MRI a bunch of people that don't actually have a stress fracture. But of course, then they're probably going to have a labral tear, and then you have to understand if that's actually the cause of their symptoms or not. Okay, so this is that 45-year-old runner I was telling you about, and this is a coronal T2 of her MRI of the hip. And you can see here a lot of really hyper-intense signal over the inferior neck and proximal femur, so that's a stress fracture. This is a more severe version of that, so you can say what we call in orthopedics this dreaded black line, and that's an impending fracture. That's someone who's going to get admitted for surgery because if we let them keep loading this, we're worried it's going to go on to a displaced femoral neck fracture, which is a totally different beast compared to a stress fracture. We can also see these injuries in other places. So this is an MR pelvis showing a sacral fracture in a college rugby athlete. All right, so now looking at treatment options. So if it doesn't have that dreaded black line, and if we think we can potentially treat it with non-operative treatment, I usually tell these patients offload, so give them some crutches and rest. I mean, no running, don't work out at the gym, lay on your couch and watch some Netflix, and then gradual progression back to activity as long as they don't have pain. And I would start them just with regular ground level walking and then increase from there. If they're still painful, then you have to kind of troubleshoot. Check their compliance, definitely refer those patients, and continue offloading for a couple more weeks to give them a little more time and then start the weight-bearing trial again. If they're still having pain, in my opinion, then they basically failed non-operative management, and then I would do screw fixation for their femoral neck. And so that looks like this. So there's 3 metal screws going across and stabilizing, and then after this surgery, again, they're going to be weight limited in terms of their weight bearing, and return to running would be probably delayed for about 3 months. This was that same 45-year-old runner that I showed you her MRI before. Essentially, she was non-compliant with my non-weight bearing recommendations, and she used crutches for a total of about 4 days. So she earned herself these screws because I just didn't feel comfortable letting her go back to running, and we did this kind of like back and forth, rest, get another MRI, okay, it still looks bad. And I finally said we should just do the surgery. And then of course, post-operatively, she listened to everything I said, and I was like, we could have maybe saved you this if you just used crutches for 4 weeks. But anyways, and then of course, risk mitigation for the future. So DEXA scan for bone density, nutritional assessment, as well as a loading assessment. And I think, be aware of future risk for stress fractures. All right, last case. So this is a 67-year-old patient you've been treating for over 6 months, and she has lateral right hip pain. She's limping, she went to PT that you recommended, she's had 3 prior corticosteroid injections, and she says they've helped for a couple weeks, and she'd really like another one because she's traveling for the holidays and she doesn't want her hip to hurt. So this patient has, greater trochanteric pain syndrome, which is a constellation of different diagnoses that include things like trochanteric bursitis, inflammation of the bursa, sometimes gluteal tendon tears or tendinopathy, IT band syndrome, and then sometimes external snapping hip, and that's where the IT band rubs over the greater trochanter. So for gluteal tendon tears, I think of this like the rotator cuff of the hip, just because that's kind of a more common injury that people are more familiar with. And this is an MRI image showing the greater trochanter and then the gluteal tendons, again, torn from their insertion here. These can be either acute or chronic, but most typically chronic. It usually affects females 50 to 70, and they have pain as well as weakness with hip abduction, so kind of like a side leg lift. They have a positive Trendelenburg sign, which we'll show you in a little bit, but when you have them do a single leg stance, they either cannot do that, or when you have them do it, and this would be the affected right side if you're looking at them from the back, their contralateral pelvis will drop because this side is unable to hold the pelvis level. And then I would say caution, because this can exist with trochanteric bursitis, so you just have to differentiate, and I think the main thing to think about is whether they're weak or not. For gluteal tendon tears, I think you see kind of a theme here, but you can consider non-operative treatment, things like injections for pain control, physical therapy, IT band stretching, and then here's an example of a greater trochanteric or trochanteric burst injection. And then for operative treatment, we think about endoscopic versus open repairs. And again, similar to the hamstring, treatment is very intensive if you do surgery for this. And again, think about those rotator cuff repairs. If any of you have had that surgery before, you know that rehab is really tough. But they're going to be non-weight bearing because now you can't walk on it, right? And their full recovery is over 6 months typically. So this was a good study out of steroid injection, and this was patients with tendinopathy, not a tear. And so they randomized these patients and essentially showed that the patients who had leukocyte-rich PRP did better than those that had a corticosteroid injection at 3 months in terms of both pain as well as PROs. And again, from baseline, both groups improved, but the PRP group seemed to improve more. And so I tell patients, PRP is reasonable to consider. I'll be, okay with doing a single corticosteroid injection, but like this patient we showed earlier, I don't want them to get sometimes I see patients in clinic, I've had 5, I had 7 corticosteroid injections, and the pain just keeps coming back. It's okay, if you've had that many, probably need further workup, and then consider changing up your treatment plan. All right. And then kind of along the same lines, trochanteric bursitis, again, very similar presentation, lateral sided hip pain, oftentimes pain when laying on that side at night, but no weakness. This is the really important thing. And so on the MRI, you'll see intact gluteal tendons, but a bunch of fluid here on the side of the bursa. And then if you do want to do surgery for this, it's an endoscopic bursectomy. I like to tell my patients I like doing this surgery. It's very satisfying, and patients do quite well, but I usually don't need to because most people get better without me. And these are just some images from that type of surgery. So essentially what we do is an endoscopic surgery where we have a camera and then a radiofrequency ablation device on the side of the hip, and here is opening up the IT band longitudinally, and then I actually create kind of a diamond-shaped window, so that's kind of the IT band release or lengthening, and then the bursa and gluteal tendons will be deep to that. And so this is kind of the gluteal tendon, gluteal musculature here, and then the IT band windowed open. And overall, I think the patients do quite well after this surgery. So something to consider if they're not doing well with non-operative treatment. All right, that's all the slides I have here. Here's a picture of my firstborn, my dog, and then my baby. And my contact information if any of you guys have any questions. And then I think we'll move on to the exam. Thank you, Gina, one of our awesome athletic trainers, for modeling this physical exam. So one of the first things I like to do when I see hip patients in clinic is have them walk. And sometimes I'll just see them walking down the hallway too, and I'll be like, oh, remember this patient's the one that's limping into the clinic room. So I think it's really important just to have them walk for you. If you don't have enough room in your exam room, take them outside in the hallway so you can actually see their gait. And you want to be looking for kind of equal time spent on each leg. If they have a shortened stance phase, we call that an antalgic gait. Importantly, the pelvis remains level with that. Gina, if you don't mind demonstrating maybe like a Trendelenburg. Not that she has a gluteal tendon problem, but you see how the pelvis drops? So she might have a gluteal tendon issue.
We're recording.
And then if you want to maybe face this way. Yep, and then maybe if you can demonstrate a Trendelenburg sign for us. So I would say, can you please show me just standing on, one leg? And I'll try to do it with, this one. Yep. And you can see, and you can stand behind them to look at the pelvis. And if the pelvis remains level, that's normal. And if the pelvis drops, that's abnormal. Okay, good. Some of the other things I'll have patients do, and I usually do this kind of at the end of the exam once they're a little bit warmed up, but things like squats. So some of my athletes, I'll say, can you do a double leg squat? And Gina, of course, is demonstrating perfect form here, but what we're looking for is that she's sitting far back, she's putting equal weight on both legs, she looks comfortable, looks easy for her to do. And then some of my patients, especially those returning to sports, I'll have them even do like a single leg squat. These are exponentially harder, but essentially you want to look for the knee going straight over the feet here. And then this is a really challenging exercise and one that they'll often do in physical therapy to help strengthen the pelvis stabilizers and then the glutes. And I think this is a fantastic test just for overall hip stability, core strength, knee stability. All right, good.
Oh, I should show not good one maybe?
Oh, yeah. You want to show a bad one? Yeah. Okay, so here's an example of a not very good single leg squat. So you see how her knee is drifting into valgus. So that's where your knee comes inwards. So that tells me that her glutes and her core are not helping to stabilize her knee. And this is also a dangerous position for injury to the knee, things like ACL injuries, et cetera. So if you see that, those are patients that would benefit from maybe a targeted physical therapy program. All right, so we'll move on to some of the exams. So first I'll have you laying down flat on your back. And then Gina is in stretchy pants, which is nice. I think for the hip exam, you want patients to not be in things that are tough to move around in. So don't have them in jeans or chinos. Nowadays, wide leg pants are in fashion again, so that's kind of nice for our exam purposes. Okay, or have them change into shorts or a gown. Okay, so I like to stand on the affected side so I can be closer to the side for ergonomics. And so one of the first things I'll do for the supine exam, and I always insist patients lie all the way down. So a lot of patients would try to do this while they're sitting up, and that's just not going to be accurate. So just lie down, relax. And the first thing I'll do is a simple log roll. So essentially what we're just going to do is roll the leg from side to side. And what that's doing in the joint is actually rolling the femoral head within the acetabulum. So if they have pain with this test, that can indicate a whole series of different intra-articular injuries. So think back to on the slide where we talked about location. So anything in the hip joint. So femoroacetabular impingement, hip arthritis, a septic hip joint, which we didn't talk about, stress fractures, things like that. The hip joint is painful. Hip fractures definitely will hurt with that as well. After that test, what I'll have them do is a straight leg raise. So go ahead and lift your leg straight up. And so when she's doing that, she's firing her hip flexors and increasing the joint reaction force across the hip. And so she's able to do that without pain. And again, this would be positive if she had pain in the hip joint and again in the front. Differentiate this from lumbar spine pathology, right? So patient has radiating pain down the back of their leg, so that's not the same. We're looking for groin or anterior pain here. Okay, lift up one more time. Okay, I'm gonna push down, so resist me. And then this is what we call Stinchfield, so basically a resisted straight leg raise. That's gonna load the hip more than a straight, her just doing it against gravity. And again, just another indication for intra-articular pain. All right, now that you've checked some of the intra-articular causes of pain, next I'm just going to examine your hip range of motion, if that's all right. So I'm gonna borrow this hip, go ahead and bend your hip and knee up. And again, this is where the flexible pants or shorts come into play. So next we wanna check hip flexion. So in terms of range of motion, this would be 90 degrees, right? Like sitting in a chair, for example, and then past 90, so you could estimate maybe this is about 120 or so. And then again, I always examine the contralateral side before the injured side, just for a baseline, and then I'm looking for symmetry. So this is hip flexion, okay, so say to about 120, and then we're gonna do external rotation. So that's coming this way. And again, I think less about the foot position, but more about the kind of hip and knee position. So external rotation this way, normal is about anywhere from 30 to 50 degrees, and then internal rotation is the opposite direction. And again, think more about what the hip is doing, not the foot. So internal rotation, and again, internal rotation, normal, anywhere between 20 and 40 degrees. Usually people have a little more external than internal rotation. From there, then what I'll do is go into the flexion, adduction, and internal rotation test, because you're already kind of in that position with your internal rotation range of motion check. So I'm going to adduct Gina's hip. She's already in flexion, and then I'm going to internally rotate. And if this causes pain in the groin, that's a positive flexion, adduction, internal rotation, or positive fader test. So this is the classic test that's positive with femoroacetabular impingement. But of note, this will also be positive in patients who have bad hip arthritis or any other intra-articular hip pathology. The next hip impingement test I like to do from this position is called the scour test. This is a less commonly known test, but many of you are probably familiar with the McMurray's test that you probably did at the last exam session that Dr. Edwards taught. And what this test actually does is we're going to take the hip through a range of motion, and we're basically trying to catch that labral tear with the hip kind of moving. So what I'm going to do is flex Gina's hip up and externally rotate her, and then sweep her into internal rotation and extension. And so you can kind of imagine while doing this, if there's a labral tear that's symptomatic, you're trying to catch it. And so I think of this like a McMurray of the hip. And you're looking for, again, pain in the groin. Some people would describe lateral pain, posterior pain. Okay, that doesn't count. This is a groin test. Okay, so I always tell people when they say, ow, that hurts, I say, where? Okay, perfect. Okay, I'll have you then go ahead and relax the leg down. So that is a majority of the supine kind of special test. I think you can also, if relevant, you can palpate some of the structures in terms of some of your bony landmarks. So is it okay if I feel in front of your hip? So I'm just gonna feel kind of over the hip flexor musculature. So some patients will have hip flexor tendonitis, which we haven't talked about as much, but usually they have more superficial pain, palpable pain, maybe pain with a straight leg raise, but normal painless hip range of motion. You can also feel some of the bony prominences, including the anterior superior iliac spine. And so what I'll do now is maybe have you flip onto your side. So I'll have you face this way. And so this lateral decubitus position is nice for examining the lateral hip. You can also examine, if you want, or if it's relevant, kind of the lumbar spine and posterior pelvis, including the sacroiliac joint in this position as well. But what I'll do is start by feeling the side of your hip. So I'm gonna feel right here, and this highest point on the femur is gonna be your trochanter, your greater trochanter. And so this would be painful if you have trochanteric bursitis. So very straightforward diagnosis. Push on it. Does that hurt? Some people are very, very symptomatic. They'll like jump off the table when you push here. Then from there, I palpate down the IT band, and you can check for any IT band tenderness. And then what I'll have you do next is go ahead and lift this top leg up in the air. And so now she's doing abduction. So if she can lift her own leg up against gravity, she has at least 3 out of 5 strength. And then I'm gonna give you some resistance, okay? So go ahead and push down. So Gina has 5 out of 5 abductor strength. So if she had a gluteal tendon tear, she may not be able to lift against gravity, or she may have pain or weakness with resistance testing. Okay, good. Now I'm gonna borrow your leg one more time. And then the next test I wanted to demonstrate is Ober's test. So that's a test for tightness of the IT band. This one's a little funny to do, so I'll give you kind of my tricks. But basically, I'm gonna borrow your leg, and I'm gonna bring your hip and knee back towards me. And so you wanna kind of extend this hip so it's extended to about 0 degrees. And I want you to try to drop your knee down to the table. So I'm gonna stabilize her pelvis, and Gina's knee doesn't quite make it down to the table, so I call this a positive Ober's test. And if you can imagine, this just indicates that her IT band is a little bit tight, and if the IT band was not as tight, you can imagine maybe her knee would be able to actually touch all the way down. And so a positive Ober's test just indicates IT band tightness, and we can commonly see this going along with trochanteric bursitis, because the IT band actually goes right over the greater trochanter. So you can imagine a tight IT band, lots of friction over the bursa, inflamed bursa, so you wanna kind of treat that with your bursitis together if they have a positive Ober's. All right, great. And then maybe what I'll have you do next is go prone. So I don't always do the prone exam. I think it's, if relevant, if they have pain posteriorly, or if I'm concerned about hamstring pathology, then I have them flip onto their stomach to do this. And if not, if their pain is mostly groin, then I'll defer this portion of the exam. But first things first, I think, if this was someone that I was worried about a proximal hamstring injury, I definitely want to be able to see the entire back of the thigh to examine for ecchymosis or deformity. And then what I'm going to do is just palpate. I'm going to feel the back of your thigh, okay? So I'm going to start distal away from the site of injury, assuming she has a proximal hamstring problem, and then I'm going to feel kind of up the muscle belly. So hamstring strains are also really common, but those are more of like a muscle level injury rather than a tendon injury, and those will often present with pain more in like the mid or distal thigh, and pain to palpation of the muscle belly rather than the bony attachment. So that's what I'm checking for here, and then I'm going to feel up high at your sit bone, okay? So you may want to chaperone for this portion of the exam because it does become a bit sensitive, but essentially we're going to feel up high kind of in the gluteal crease, and then you're going to feel the bony prominence, which is the ischium, and that's where the hamstrings originate. So people with hamstring pathology will have sometimes pain at the ischium. For those with complete hamstring ruptures or avulsion injuries, sometimes you can actually feel a palpable defect, so there'll be like a hole there compared to the opposite side where you actually feel your fingers kind of fall into it. Okay, so after palpation, the next thing I do is strength testing. So what I'll have you do, so the hamstrings, again, remember their action, they do knee flexion and hip extension. So first I'm gonna check knee flexion, so again, check the contralateral side first. But what I'm gonna have you do, Gina, is go ahead and pull your heel in towards your buttock. So kind of like a curl. Good, I'm gonna give you some resistance. Good, so she should be able to resist me. A lot of hamstring injured patients will either have pain, like cramping in their hamstring, or weakness when you do this. And again, compared to the contralateral side. And then to check resisted hip extension, what I have them do is start this position with the knee and hip, with the knee flexed to 90. And then Gina, I want you to try to kick the ceiling with your foot. And then I'm gonna resist her by putting my hand here, and then push down. And again, this is the resisted hip extension part of the exam. A lot of acutely ruptured hamstring patients won't even be able to get their leg off the table for this. So that's one way to check that as well. Okay, and then let me have you go ahead and roll back onto your back. And then a couple more things I wanted to point out. For pain over the posterior pelvis, another common exam that we'll do is the Fay-Burr test. So that's flexion, abduction, and external rotation. And I like these tests, this and Fay-Burr, because it kind of says, it's not like some person's name, but it says like what the test is and the name and the abbreviation. Okay, so for Fay-Burr, essentially you're gonna have them go, and what I tell patients is do like a figure 4 stretch, and you can kind of show them on yourself, but you're gonna cross the ankle over the other knee, and then you're gonna give them a little downward pressure here. So, and then you're gonna say, if that's uncomfortable, where do you feel the pain? So if it's an SI joint problem, a lot of times they'll feel pain in the contralateral SI joint because you're basically compressing the back of the pelvis together. However, this test is also commonly positive in patients with intra-articular pathology. So if they tell me that it hurts in the front, it hurts in my groin, that can be the case if they have a labral tear or hip osteoarthritis. All right, good. All right, go ahead and sit on up. So that's the majority of what I would do for my typical hip exams. At this point, I think happy to take any questions from the audience.
During that where you test the hip, do you like axial load the hip as you are arranging it to try and feel the clip, or?
Yeah, so the question was about the scour maneuver, or the McMurray's of the hip, as I call it. And the question was whether we do any axial loading of the limb. I don't usually axially load. It's just more of just sweeping the hip in a circle is kind of the words I use to describe it to the patients.
And hi, Stephanie. I was going to moderate, so I think we have time for how about 2 more questions, and one of them is in the app. So thank you, Dr. Wong. Can you speak to the kinds of sports injuries that might cause FAI? Are there certain sports or movements that you ask about during your history? So I know you showed the picture of, say, the catcher and the hockey player. Yep. So maybe if you could speak a little more about that, please.
Yeah, absolutely. And I think, in most of our athletes who have hip impingement or femoroacetabular impingement, it's not like a specific sporting injury like an ACL tear, right? It's not like, oh, I did this one thing on the ski slope and then, I had a ton of pain after. It's kind of like this gradual onset, maybe chronic type pain. And sports that involve running and kicking typically are the sports that are implicated in development of femoroacetabular impingement. So these would be your soccer players, commonly hockey, catching in baseball, but we can also see them in things like basketball, football. So I would say running. I mean, literally any sport that involves hip flexion, which is almost all of them, can be associated with development of this condition. But when you ask patients about it, if they're presenting as an adult, a lot of them will say like, yeah, I had a really active childhood. I played multiple sports growing up, and a lot of those patients can present later in life with hip pain.
We have time for one more.
I'm sorry. Are those people that you would consider to have some genetic or predisposition, or not necessarily?
Oh, that's a good question. So the question was whether hip impingement has a genetic predisposition. So I think that I don't know if we totally know the answer to that right now. I think for CAM type FAI, so that's the bump on the femoral head-neck junction, there are really interesting anthropology studies that were done where basically they showed that many, many, many centuries ago, CAM type FAI didn't exist. And the thought is maybe because people did not have things like sports or recreation, and they were maybe doing other activities focused more on survival. And then now in the modern era, we have luxury of recreation time where we're playing sports for fun. For pincer FAI, I think because the pathophysiology is different, right? The hip socket is just extra deep. That potentially could have a genetic predisposition, but I don't know if we have all the answers per se there. Yeah.
What about on-field exam for adduction muscle injuries of the hip?
Yeah, good question. So the question was regarding on-field evaluation for adductor injuries. So that's one muscle group that I didn't necessarily go into as much for this exam. What we typically see for these athletes would be kind of pain far medial. So when we said groin earlier, a lot of patients might say like more anterior, but far medial pain specifically after a powerful activity, maybe pushing off or running, and then they feel either a pop or pull and then have a lot of pain in their groin. I think for on-field, I don't know if I do a ton of exam just because it's kind of a sensitive area in public oftentimes. I think if you have a private space, sure, you can go ahead and examine. For most of the athletes on the field, I think working with trainers like Gina, we'd often say, let's do an exam, let's range your hip, make sure nothing is fractured or dislocated first and foremost. If we think it's more of like a muscle strain or injury, see how the athlete's feeling in terms of their pain level. Can they walk? Can they jog? If yes, then I would be okay with them trialing a return back to the sport. If they cannot, if they're really painful, and they're not able to bear weight, then especially in my adolescent athletes, I might consider having them get an x-ray after just to rule out like an avulsion fracture. So in our adolescent patients, instead of having like an injury to the tendon or muscle group, oftentimes they'll actually pull off a chunk of bone from the pelvis, and the x-ray is really the only thing that's gonna be able to tell us that. So if they're so painful they can't go back or they can't weight bear on that limb, then they're gonna get an x-ray after and we'll just hold them out. But I think it's a tough sideline exam. I think you can check just general range of motion, general strain, things like that, but you're probably not going to disrobe or palpate per se the adductors just because of, just being in public, I think.
Is there anything on the exam that would make you think of a sports hernia?
Oh, good question. Yeah, so we didn't get into this as much, but the question is about sports hernia, which is technically a misnomer. It's not like a true hernia. So as you know, kind of inguinal hernias involve kind of the, the kind of intestines as well as a defect in the abdominal wall. A sports hernia really, the phrasing I like to use is like a core muscle injury. So that's an injury between typically the rectus abdominis here and then the adductor musculature. So sometimes these can be acute injuries, especially in athletes when they're running or extending their hip back, and they'll feel kind of like pain along the pubis or sometimes pain along the adductors. You can do like a resisted abdominal crunch. So if you want to maybe demonstrate, Gina, have their hip and knees flexed. Here, go ahead and flex up your knees to maybe 90. And then I'm going to have you cross your hands over your chest and try to like crunch up, and then I'm going to give her some resistance. And if she has pain either along the rectus abdominis, pubic bone, or adductor, that can be a sign of a core muscle injury. You can also palpate along the pubic bone to check for that as well. And then for resisted adduction, here, maybe extend this leg. Resisted adduction, you can kind of, and again, we didn't get into this as much as kind of a specialty exam, but you can have them bring your knee up to the midline, and then I'm going to resist her. And then you can also palpate down the adductors here to check for any adductor injury. Core muscle injury, I think, is a little bit of a tougher diagnosis, but if they're not getting better with your typical treatment for an adductor strain or abdominal strain, as you think, those might be patients you want to refer. The test that I typically get to diagnose a core muscle injury is actually an MR of the pelvis, but it has to be done in an oblique plane. So the radiologists have to protocol it to actually see the injury there. Good question.
Yeah, thank you so much, Stephanie. I think we need to wrap it up. Obviously, this is a very hot topic, and I think maybe you could stay for just a few minutes longer if people have more specific questions. So thank you so much for coming to our session today, and we will see you tomorrow morning.